Thank you very much, the organizers, for giving me such a very clinical topic. I would not have been able to do justice to Dr. A.K. Singh's topic at all. Not a clinical research-oriented person, but excellent talk, whatever I was able to catch. And so thank you very much. And I really, I can probably do justice to this topic because I come from a college which is the first premier college in a resource-poor setting. So even before we start learning our internal medicine, this resource-poor setting is kind of honed into us quite a lot. So Anjali is my junior from the same college. So thank you again, Neeta and Anjali, for inviting me here. And it's always nice to be in Pune. So yeah, so before I start this, the most important thing which we kind of talk about is always investigations, and in diabetes there is no end. We can start with a random blood sugar, a fasting and all, and when we talk about annual checks is something which we always miss in the whole spectrum. So the first three which I am choosing is to be able to detect and prevent the larger complications. So we have macrovascular, we have microvascular complications, and we have peripheral neuropathy. So when Neeta opened up this topic, I went around asking my seniors, asking which three should I pick up, and they unanimously, they all stuck to these three things. You said macrovascular complication, micro and peripheral, and they made my job easier. So why is it important? Because it enables the physician to control diabetes through dietary and lifestyle modification, brings blood sugar under better control by optimizing pharmacotherapy, prevents the progressive nature of complication, educate patients on importance of annual screening and good glycemic control. Something which is very, very, very important is that we should try to prevent complications, and once complications, then it pretty much is like like a palliative life most of our patients lead when too much of complications set in. So what are the advantages? They are easy to perform, low in cost, once in a year frequency, clinical-based investigation can be done at bedside. The only thing which we need to remember is to ensure that it remains in your radar all the time. Yearly annual test, most of the time even the A1C gets missed, and the annual definitely gets, these three complication checking definitely gets missed. What are the advantage? It can be performed by the physician with adequate training. It's non-invasive, non-time consuming, and there is no discomfort to the patient. Disadvantages: need for special training in echo and retinoscopy. If you want to do, I think I missed some slides here. Investing in medical equipments and need to motivate patients and spread greater awareness. So coming on to the investigations which I have chosen, one is retinoscopy. I think it was kind of honed into us when we were doing our internal medicine that each PG has to carry a retinoscope, and it can be a very cheaper version, doesn't have to be a very expensive one, and ensure that we check retina for all the patients, whether they are non-diabetic, diabetic, non-diabetic, anything, just to get the hang of it. It was mandatory for us. If on the rounds we don't have the retinoscopy, we were asked to go out of the rounds. This is something which has been very, very, so it's very easy to perform once you get the hang of it. Does not necessarily need pupil dilatation most of the time. Helps detect retinopathy at an early stage. Diabetic retinopathy is one of the most easily preventable cause of blindness, and the world statistics says that 1/3 of our diabetic patients suffer from diabetic retinopathy worldwide. So this is just how the retinoscopy is done. So this is the retinoscopy pictures. We can very easily pick up. Also, it says that eye is the mirror of what is happening much, much down. So what we can even pick up easily about nephropathy, if there is a retinopathy, we can correlate it with the nephropathy. So the different stages of diabetic retinopathy we pick up is the hemorrhage, the microaneurysm, going on to the cotton wool spots. I don't think I need to elaborate here. I'm sure everybody is an internal medicine minimum here, so I'll move on. Echocardiography, very, very easily done, non-invasive, and used as a fitness tool for most surgical fitness plans. So scans the heart, determines the ejection fraction, motions of the wall, presence of valvular deficits. The minute we tell the patient, okay, you need to go for your heart scan, they immediately get paranoid thinking it's something big or they have to do a CT angio or something like that. Then we say, no, 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 it's as simple as getting an ultrasound abdomen done, and it's just an echocardiography. So makes sense to get a patient to get an echocardiography at least once a year. I have been part of a very big cancer networking in Chennai, where I used to see almost 40, 50 diabetic patients who are undergoing onco treatment, whether it is chemo, radiation, surgery and all. Believe me, the double whammy which the heart faces when they are on onco medicines and on diabetes is crazy, and most of the time their treatment gets limited if they have cardiac issues. The worst thing in our patients is that these patients actually start taking cognizance of their diabetes once they are detected to have some form of cancer, and by then it is already very late. So when we went and approached the cancer hospital saying we need to have mandatory diabetes screening along with cancer screening in the society, we faced a absolute gamut of very weird reaction, right from yes, definitely, to oh, if we start talking about diabetes, patients will forget cancer. So I mean, this is the type of response which we get from medical people, and then you can imagine if the diabetes screening is out, the complication screening definitely does not come into the radar at all. So it can pick up any recent pre-existing or ongoing cardiac event. Important bedside stool, very, very important with the presence of the bedside echo monitor. It's just a probe which gets fixed into a existing ultrasound. The only problem is that again, everybody should go through this at least once. Ease of operation. Yes, of course, we need to have trained echocardiographists to do it, or we should have a cardiologist. But I think most PGs can pick up if there is a regional wall motion abnormality, or if there is a tachyarrhythmia. The minimum things can be. We don't need to go into the dimensions there, but definitely we can pick up. So diabetic cardiomyopathy is a huge complication. It's due to either the metabolic derangement, microvascular disease, and myocardial fibrosis, all three in one, and it can, so it's easily picked up. So prominent histopathological findings in diabetic patients without CAD hypertension are the myocellular hypertrophy and myocardial fibrosis. It can show changes in the structure and function. It will pick up systolic dysfunction easily, left ventricular hypertrophy, and worldwide incidence is around 12%. This is how the this is a normal, and this is how the diabetic cardiomyopathy, very basic, dilated left ventricular wall with very sluggish wall motions will easily show us that yes, there is some amount of damage to the heart. Biotheziometer, another very, very, I think minimalistic and used. Half of us don't even know how to interpret the biotheziometer. It started with a monofilament, and now we have fantastic machine. All the patient has to do is just walk in. Even the cost of the overall expense to a clinic is not that much. The only thing is that we do not use it as much as we should. So biotheziometry is a device which is used to measure the threshold of appreciation of vibration in patients. A decreased sensitivity to this vibration indicates a neuropathy. Even before a patient goes in for a nerve conduction study to prove peripheral neuropathy, this gives an indication that where we are, whether there is a in fact, biotheziometer also picks up peripheral neuropathy before the patient develops paresthesias and numbness if we use it annually. Early indicator of impending neuropathy, worldwide incidence is approximately 6.3%. Preventive and corrective measures can be initiated early. That's a very, very, very big amount. So that's how the neuropathy, it's just a histopath. So these are the different grades we have. Grade 0 is there is no open lesion, but definitely will show some pressure changes there. Grade 2 is superficial ulcer. Grade 1 is superficial ulcer. Grade 2 is deep. Grade 3 is abscess. Grade 4 is gangrene and of the forefoot, and grade 5 is the entire foot. In fact, I have had lot of discussions with the surgeons, because surgeons want to do conservative surgery when it comes to these patients. They will only start with one toe, then they will go to mid-foot, then maybe above ankle and all. But when we can prove that this patient is already having a severe peripheral neuropathy, the osteomyelitic bone changes have set in, maybe they can go in and do a little more radical amputation, because that will help us get better glycemic control. Because the patient keeps hoping that, okay, even with this sugar, maybe my foot can be saved, but that is not how it works. Most of the time I've seen, including my own uncle who went in for a below knee amputation, eventually they started with one toe and then they went on to the mid foot and then above ankle, and then finally it was the below knee, in spite of the fact that he had proven diabetic neuropathy. So these are the three major ones which I have picked up. There's a diabetic foot, biothiometer, this is how it looks. When there are pressure changes, it will have a little more, the color changes to red, but there are some in which it doesn't have this color vision, they have the grading, there are number grading is there. So the take home message is retinoscopy, echo and biothiometer can be offered to all diabetic patients once a year, helps in early detection of micro and microvascular complications if done right, and physicians can plan treatment better or refer for higher care promptly. Thank you very much.